patients who having stents. So the combination of atrial fibrillation and acute coronary syndrome is very frequent. And as we all know that when you have a patient with atrial fibrillation, you need to treat the patient with anticoagulation because the data showed by Ramsey earlier that antiplatelet therapy is not as good as anticoagulation. So this is a major consideration for those patients. However, patients who are undergoing stenting or PCI or ACS, they will benefit from antiplatelet, particularly dual antiplatelet. So once you have a patient with atrial fibrillation and acute coronary syndrome, you have three different things to combine together, and let's see what the data suggests to us, in fact. The first study to address the combination of anticoagulation and antiplatelet therapy in patients with ACS in combination with atrial fibrillation was the WOOS trial. This trial is overdue. It was published about 6 years ago and looked at patients who need both anticoagulation and antiplatelet, and they were randomized to either warfarin plus single antiplatelet agent, which is clopidogrel, versus warfarin plus dual antiplatelet, or DAPT, what we call it. And they looked at safety and efficacy at 1 month and at 1 year. And the data was astonishing at that time because when you have a combination of triple therapy, we call it, 12 antiplatelet plus anticoagulation compared to 1 antiplatelet and anticoagulation, there was a major increase in the risk of bleeding. Twice, if not more, the risk of bleeding. But sometimes we say that we will live with a little bit of more bleeding if that is more effective. Let's look at the efficacy point of view. It did not help us at all. In fact, when you use more anticoagulation plus dual antiplatelet, you increase the risk of death, myocardial infarction, stent thrombosis even. When you feel that the blood is too thin, it's good for stent. Sometimes it's not valid. The hypothesis failed in this particular scenario. Some people, they will question the results because they say, well, why it increases stent thrombosis? I think maybe sometimes when you have a major bleeding, you have a cascade of thrombosis, and that will end up with more comorbidities and sometimes even mortality. When you look at secondary endpoints of that particular study of death, myocardial infarction, target vessel revascularization, stroke, stent thrombosis, it was at least 50% more with the triple therapy compared to the double or the combination dual therapy. Now, all-cause mortality was more than double with the triple therapy compared to double therapy or dual therapy. And that raised a lot of questions at that time, and I actually changed my practice, and from 2013 I used 1 anticoagulant and 1 antiplatelet, particularly thioviridine, in patients who undergo stents and the combination of atrial fibrillation, because higher, not always better, sometimes it's a killer. Now, with the introduction of direct oral anticoagulant, the questions has to be restudied and the hypothesis has to be re-established again. However, we have 4 anticoagulants, we call them direct oral anticoagulant. 3 of them are available in Jordan. The first 3, Pioneer AF PCI trial, looked at the combination of dual therapy versus triple therapy. Similarly, dual, looking at dabigatran, double therapy versus triple therapy, and we'll talk a little bit more details. Augustus Epixaban looked at double therapy versus triple therapy in both combination of dual versus warfarin. Interest will not mention about it because the drug is not available in Jordan. So looking at Pioneer AF trial, looked at randomized clinical trial of over 2,000 patients with atrial fibrillation and undergoing PCI, and randomized them to 3 different categories. One category looked at rivaroxaban 15 mg, reduced dose in combination with clopidogrel. The second randomized arm was rivaroxaban 2.5 mg twice daily, plus dual antiplatelet therapy for 1, 6, or 12 months, followed by rivaroxaban plus 1 of the antiplatelets, low-dose aspirin. And the third arm was vitamin K antagonist, which is warfarin plus dual antiplatelet therapy for a specified period of time, 1, 6 and 12 months, followed by vitamin K and low-dose aspirin. From the first look of this trial, you know that the most trial suggested that dual therapy is better than triple therapy. So why you include a triple therapy in these trials? It is just blowing my mind, in fact. But looking at the data here, we notice that dual therapy is better than triple therapy in the face of bleeding risk. So less bleeding risk with one antiplatelet and one anticoagulant rather than dual antiplatelet and one anticoagulant. And that did not, reducing one antiplatelet agent did not translate into further increase in other efficacy endpoints. So suggesting that dual therapy is better than triple therapy. When you look at the re-dual, which is dabigatran, similarly looking at dual therapy versus triple therapy using the two combined doses of 150 milligram twice daily or 110 milligram twice daily compared to warfarin. Similarly, the dual therapy was better than the triple therapy, and this is, we know it before. But however, when you look at the design of the trial, of the Augustus trial, it was really, to my understanding and my belief, that probably this is translated into the best answer of the position of antiplatelet anticoagulation in the combination of AFib and ACS, because it randomized patients on the basis of anticoagulation to either apixaban versus warfarin. But on top of that, each arm was randomized to aspirin or no aspirin, suggesting that you need to study the hypothesis from the beginning, not comparing yourself to an inferior therapy, which is warfarin and plus triple or double antiplatelet therapy. So all patients received clopidogrel or other PY212 inhibitors, but the randomization was either direct oral anticoagulant apixaban versus warfarin, or plus presence of aspirin or no aspirin. And I think this is the best design of a trial you can have. We have the primary endpoint, it is bleeding. Secondary endpoints, death, hospitalization, death, ischemic events. Looking at the results, vitamin K antagonist was in fact inferior to apixaban in the risk of bleeding. So there was about 50% more risk of bleeding with warfarin compared to apixaban. When you look at the placebo compared to aspirin, adding aspirin to the combination therapy has higher risk of bleeding. That was known to us before from the WOOS trial, but it was confirmed in this particular study. And the results of major bleeding, whether it is defined by any measurements, vitamin K antagonist, warfarin plus aspirin was the highest risk of bleeding. Apixaban plus aspirin was lower, and the best combination was apixaban plus placebo. But remember, all four groups, they have PY2 B2 by Y12 antagonist, particularly clopidogrel. So patients with ACS or undergoing stents and they need anticoagulation for atrial fibrillation, in this particular study suggesting that an antiplatelet plus direct oral anticoagulant is the safest protocol to manage their antiplatelet and anticoagulation issues. Death and hospitalization, if you follow the vitamin K antagonist versus apixaban, there was borderline benefit from apixaban compared to warfarin, suggesting it is safer, but it may be more efficacious in this combination to treat those patients. Now, if looking at ischemic outcomes, apixaban versus vitamin K antagonist, they are mostly similar except with a risk of stroke, definitely lower risk of stroke with apixaban compared to vitamin K antagonist. And if you look at the addition of aspirin or placebo in ischemic outcomes, there was no much of a difference, suggesting that adding aspirin to your original treatment, it just gives you more bleeding, but no more benefit of efficacy. And direct oral anticoagulant with apixaban was superior to warfarin in the combination therapy of AFib and ACS. I will conclude without delay here that in patients with atrial fibrillation and the recent ACS, or PCI treated with P2Y12 inhibitors, and an antithrombotic regimen that included apixaban without aspirin resulted in less bleeding and fewer hospitalizations without significant differences in ischemic event. That regimen that included a vitamin K antagonist, aspirin, or both. So it is a clear, well-defined, and well-hypothesized study looking at the overall benefit of the combination of dual versus triple therapy, direct oral anticoagulant versus vitamin A antagonist. And in this particular study, the winner was direct oral anticoagulant apixaban without aspirin, in addition to B2Y12 inhibitor. Thank you very much for your listening.
Great, we'll have some questions.
Question, please.
Actually, I want to start with a question, if I may. Imad, how long do you keep patients on Plavix? Let's say you're putting somebody on apixaban and Plavix, you put a stent, and then how long do you keep them? 1 year, 2 years, and you stop after 2 years?
Great question. I think once you have a long-term indication for anticoagulation, you have to modify your protocol. Before, we used to treat them with one antiplatelet therapy for life, whether it is aspirin or clopidogrel. Now the data suggesting that you don't need aspirin, you need clopidogrel plus the oral anticoagulation. So if the patient has a simple angioplasty with 1 or 2 stents and not complicated, not left main, not calcified, not diffuse disease, you can stop the clopidogrel after 1 year, and he will continue with oral anticoagulant, and that would be enough. However, once you have the patient with more complex disease and more stents, and particularly if he has SVG, left main, multiple diffuse disease, I think I will keep him for life with the antiplatelet and anticoagulation.
Dr. Imad, how do you deal with those elderly people who turn to be Plavix resistant and have AF? Do you use ticagrelor or prasugrel combined with?
Yeah, I think this is a tough question, but I will tell you from the beginning. What do you mean by Plavix resistance? Is it a pharmacological resistance or is it a clinical resistance?
Let's say they had an event of acute thrombosis while on Plavix.
This is different. When you have a clinical resistance, you are entitled to make some changes. One of them is to upgrade your antiplatelet therapy, whether if he doesn't take aspirin, to add aspirin, or if he already taking aspirin and you think that the clopidogrel is not enough, you can upgrade it to ticagrelor or prasugrel. This is another thing. Now with the direct oral anticoagulant, I think, and the patient already in atrial fibrillation, sometimes we upgrade the dose of the anticoagulant also. So it depends if the failure or the resistance is a stent thrombosis or some other manifestation of thromboembolism. If it is stroke, if it is something different, we tend to upgrade the dose of the anticoagulation. If it is a stent thrombosis, we probably add another antiplatelet therapy in this particular scenario. Yes.
That's the only risk.
Well, bleeding is sometimes leading to more complications. If the bleeding is major, you could end up with hypotension, transfusion. All this is carried higher risk of complications. So bleeding alone is the primary, but secondary outcomes also is affected, in fact. So nowadays, if the patient does not have a clear indication to add another antiplatelet agents with anticoagulant, we don't do it.
Non-inferiority, but at least we need something that is superior to show bleeding I think what Ayman's trying to say is that in our local studies here, we're not seeing the problem of bleeding in patients who are on oral anticoagulants. We're more seeing events. And so if we, and this may be because our population of patients with atrial fibrillation, maybe coronary artery syndrome, are younger than the patients that they see in the West. The patients in the Western trials are older than the population with similar problems in our population, and that's why they don't have the same rate of bleeding complications as we see in the West. This is interesting, and I agree with you. We have to look for things that, ways to treat these patients that are superior in terms of efficacy and stroke prevention rather than maybe bleeding. But this is specific to our population in the Middle East.
Okay. Doctor?
My question for Dr. Imad. Practically, I want to ask you, if you have acute coronary syndrome with atrial fibrillation, you give your patient from the start dual therapy, or you give the first period triple therapy first month, then you continue dual?
Yeah, this is a great question. The question is that once you have a patient coming with acute coronary syndrome and he needs a stent, at the same time he's in atrial fibrillation, do you give a period of triple therapy and then you cut down the aspirin, or you start from the beginning with the double therapy? I start with double therapy from the beginning. I don't give an extra unless the patient has extremely high risk of thrombosis, particularly if he has bifurcational stents and uses two-stent technique. But in a regular PCI with atrial fibrillation, I start from the beginning with one antiplatelet, clopidogrel or ticagrelor, plus an anticoagulant. So I don't give aspirin for a specific period of time.
أنا عندي سؤال للدكتور محمد كونه he's an electrophysiologist. Is there any reason for putting patients on an anticoagulant and aspirin in the absence of an acute coronary? With acute coronary syndromes or with stents, we usually start with both medications, and then after a while, maybe a year, we stop the aspirin, we continue on a single agent, which is an oral anticoagulant.
No,
is there a reason for any reason to just continue patients on dual therapy with an anticoagulant and an aspirin beyond the first year after an acute event?
No, actually, we can stop the aspirin afterwards, but we always have to keep the anticoagulation. It's just because AFib is such a backstabbing disease where even if sometimes you don't find it, the first presentation can be a stroke. So they don't really have to keep both.
So this is a very practical point. If you have a patient with non-valvular atrial fibrillation, you have that patient on anticoagulation, even if that patient had a history of a bypass surgery or had a history of an acute coronary syndrome, ST elevation MI or non-ST elevation MI, or had a stent or multiple stents, after they go through the acute phase of their events and they've been treated for maybe a year with both agents, then after the first year, sometimes it's even shorter than 1 year, there is no reason to continue patients on both treatment, on an antiplatelet agent and an anticoagulant, because this will only increase bleeding with no clinical benefit from using both drugs.
There's a few caveats to this. One of them is that once you use rivaroxaban, you have to upgrade the dose from 15 to 20 milligram after you stop your antiplatelet agent, which is extremely important. Just stopping the antiplatelet agent without increasing the dose is sometimes not adequate because the risk of stroke and thromboembolization is higher. And the other caveat, as I mentioned earlier, if the patient is having really complex stenting, I prefer to keep him for a longer time with antiplatelet therapy. It was not studied specifically for this particular group, but it was addressed with other studies. Once you have more complex anatomy, more complex stenting, they will benefit from longer duration of DAPT. So these are the two caveats where you will continue with either an antiplatelet agent for longer period of time, or you upgrade your anticoagulation dose.
If Dr. Muhammad, the patient was having acute syndrome with atrial fibrillation, and he was treated for the acute syndrome, and he was on dual therapy, then he was ablated for his chronic AF, and now he is in sinus. Would you continue the anticoagulation or
Absolutely.
stop?
No, we all go by the CHA2DS2-VASc score, even though that we ablate an AFib. Ablation is not 100%. And if your paroxysmal AFibs, at best, can give you, if found early, can give you 90% success rate. that drops significantly for persistent AFibs. AFibs can drop to 60%, even 55%. So it's not really, AFib is not really treated by an ablation per se, because it's not really 100%. So if the patient wants to be off blood thinners, in my practice, we either place a Watchman or a left atrial appendage closure, or we implant a micra to look for atrial fibrillation. And if the patient truly is free from AFib, then we could stop the anticoagulation, but we do have to discuss that with the patient, especially with those CHA2DS2-VASc that are high, that there's a recurrence and then you could get a stroke. So that's basically what we've been doing.
I have a question. If the patient is already on ticagrelor or prasugrel for acute coronary syndrome and he developed atrial fibrillation, do we give the NUAC with the same antiplatelet with ticagrelor, or we change to clopidogrel? And the other question, the dose of dabigatran will be 150 or 110, for example?
Yeah, this is a great question, actually. We'll start with the second one because it's easier. Well, the 110 was more as efficacious as the 150 without the extra bleeding. So when you combine it with clopidogrel in acute coronary syndrome, we go with a 110 twice daily, as I mentioned, unless there is a specific indication that the patient need a higher dose because of prior failures. So this is well established, and we take it granted. Now the antiplatelet, whether P2Y12, whether it is clopidogrel or others, when you have the combination, definitely, although the ticagrelor was not very well studied, but some of the studies have included patients with ticagrelor and suggested that whether it is clopidogrel or ticagrelor is the same. Prasugrel was less included in the studies, but I think we can take the liberty to extrapolate and to include that into the formula, and I think it is reasonable. Judgment suggests to us if your best antiplatelet agent is prasugrel or ticagrelor, you can substitute it for clopidogrel, and that should be okay.
Dr. Ramzi, question. We don't have a comparison between different agents of NUACs. So for using in case of non-valvular AFib, which one will you prefer?
I think هذا سؤال لعماد. And I use all of them, to be honest with you. I cannot think of I've used them all in my patients. Sometimes you get a feeling that this agent might be appropriate for a certain patient, while another agent is appropriate for a different patient. But I don't just stick with one medication. I think they're all good. And as I said in my lecture, it's unfair to do comparisons between the numbers and results of the different trials, because these are different patients' populations. So the patients that were studied with one agent are different from the risk profile of these patients. And if you talk about the age and maybe the gender of patients in the different trials, they're different. So you cannot compare the results, the numbers of one study to the results and numbers of another study. We think that all of the agents that are in the market now they're all good. They've all proven effective in prevention of stroke and systemic embolism. They're all proved that they were safer than warfarin in prevention of bleeding. So it's up to you. It's up to what you're comfortable with, but they're all can be used in such patients.
But the risk of bleeding is lower in apixaban group.
Yeah, but apixaban was never compared directly head-to-head with the other agents. So if you look at one of the, like Aristotle's study with apixaban, yes, you have the incidence of bleeding is low, but of course, there was also a decrease in bleeding compared to warfarin in the other trials. So what we can deduce from these trials is that these agents are definitely more effective than warfarin. They're safer than warfarin, and that's why we like to use them.
Question for Dr. Imad. Now, if you have complex PCI and AFib, you use aspirin plus Plavix or clopidogrel or ticagrelor, and you adjust the dose of the new oral anticoagulants, or you keep it on the maximum dose?
The question is if you have a complex stenting and atrial fibrillation,
yes,
whether you use triple therapy or
Triple
double therapy
no,
and
triple
upgrade of the
therapy.
dose?
With the high dose of oral anticoagulant or lower dose?
I think this is a personal judgment at the time of the procedure, and you evaluate your risk of stent thrombosis. If you think that the patient is extremely higher risk, I don't mind using 1 month or a couple of weeks of triple therapy.
With the highest dose of oral anticoagulation?
We don't use the highest dose. We use the studied dose of oral anticoagulation in that particular study. If you use an apixaban studied at 5 milligrams twice daily, if he is elderly or have renal problems, 2.5 twice daily. But we don't upgrade the dose of anticoagulation for PCI. We upgrade it for failure in stroke or peripheral atheroembolization, because extra anticoagulation does not prevent stent thrombosis. If your concern is a stent thrombosis, upgrade the dose of anticoagulation is not helpful. Adding another antiplatelet is helpful, or changing to more potent antiplatelet may be helpful. But upsizing or upgrading the anticoagulation is definitely not the way we approach it.
According to the ACS guidelines, when you use rivaroxaban, you need to lower the dose to 15. But in case of dabigatran, 150 by 2 is preferred over 110 by 2, class 2B.
Not in the presence of?
In the presence of clopidogrel.
Okay.
Doctor?
So, Dr. Imad, please. When you have a patient with acute coronary syndrome and AF, and you cannot give no, for example, when you have moderate to severe mitral stenosis.
Yes.
You continue with vitamin K and aspirin, or without aspirin, or what your opinion?
Now the question here, just to repeat, once you have a patient with mitral stenosis and he has also acute coronary syndrome, what is your plan of therapy? Once you have mitral stenosis, this is called valvular atrial fibrillation. So it is a completely different category. We have 2 indications, we call them valvular atrial fibrillation. One of them is significant mitral stenosis, and the other is the metallic or the non-biological valves. These, they need vitamin K antagonist, and dual DOACs, they don't work for this kind of indication. So, yes. So once you have this patient needing warfarin, if he has a stent or acute coronary syndrome, he needs more than aspirin. He needs a P2Y12 inhibitors, whether it's clopidogrel or ticagrelor. Aspirin alone would not be enough in this particular scenario. Once he is out of the acute coronary syndrome, or he's been treated for a year at least after his stenting, you have the liberty to drop the antiplatelet agent and continue with warfarin alone. Remember, warfarin was a good anti-thrombotic, anti-stent thrombosis in the early ages when we did not have dual antiplatelet therapy. Patients were treated with warfarin. So with the long term, after stenting or after resolution of the ACS, 9 to 12 months after ACS, you are entitled to treat the patient with anticoagulation. If he has mitral stenosis, it would be the choice warfarin without the aspirin. Only warfarin, yes.
A patient with normal sinus rhythm, acute coronary syndrome, and ectatic coronaries with sluggish circulation.
Yes.
What is the role of DWAC?
Well, if you want to stick with the recommendations, you can treat those patients with warfarin. If you want to extrapolate, as we are physicians, you are entitled to do clinical judgment. You can use DOACs, and that could cover both the coronaries and the atrial fibrillation. Or your question is normal sinus rhythm?
Patients in normal sinus rhythm.
Yeah. Well, yeah, it depends on the degree of the ectasia in particular. If the patient is having mild ectasia, severe ectasia, I think you are entitled to dual antiplatelet therapy. That would be enough. If you think the patient will benefit from anticoagulation, I don't mind dealing with that as extrapolation to use direct oral anticoagulant. No, without. Just for ectasia, anticoagulation is enough alone. We used to treat it with warfarin, so I take the liberty to substitute warfarin with a direct oral anticoagulant without antiplatelet.
Can I comment on the ectasia?
Yes.
In Jordan, the only study about ectasia was done many years ago at the University of Jordan, which actually looked about maybe 300 patients with ectasia. Those who have the worst prognosis were those who have 3-vessel ectasia with diffuse involvement. And those are, I think, the patients who should be on warfarin or DUAX. If you have 1-vessel focal ectasia, you probably can get away with the dual antiplatelets. But the Jordanian data, which we published in the medical journal many, many years ago, looked at all the patients coming to University of Jordan, maybe 250 or 300. And those who died were those who have 3-vessel disease, diffuse ectasia. So if you have 1 vessel, mild to moderate, 1 antiplatelet. If you have 1 vessel, severe dual antiplatelets. But if you have 2 or 3 vessel disease, diffuse ectasia, then you'll probably be on warfarin.
But this is, yes, these are the patients who come in with coronary artery disease, who are symptomatic of coronary artery disease. When you do their angiogram, you find that they have ectatic vessels. So this is a patient with ectasia and coronary artery disease. Now that we're doing CTs, we have a lot of patients who are asymptomatic, who have no coronary artery disease or very mild coronary artery disease, have ectasia. And these patients are asymptomatic. These are usually have no symptoms, and I don't think these are candidates for even antiplatelet therapy. So there is no evidence that treating these patients with antiplatelet therapy is of any benefit to these patients. So the population you're talking about are patients who present with coronary artery disease. With,
these were cathed because
and they were cathed, and they were found
pain.
to have ectasia.
Yes.
And I agree with you. They're candidates for antiplatelet therapy or even anticoagulation because they have coronary artery disease, and they probably sometimes require interventions on top of the presence of ectasia. But ectasia alone, we see it very commonly, and it's mostly focal, as you said. It's involved 1 segment in 1 coronary or 2 coronaries. And if it's no consequences, these patients are usually asymptomatic, and they carry on with their lives without even the need for antiplatelet therapy.
Yes, if they have no symptoms, I agree.
Any more questions? I have a question to Dr. Tabbalat. You mentioned something very important, which is a second stroke in your presentation, which is something very important. Now, what's your practice when somebody comes with a stroke without AFib? You cannot see AFib, and then somebody comes with a stroke. Do you guys implant any kind of monitoring device to look for AFib, just based on crystal AF?
Yeah, if you have a stroke and you cannot explain why the patient had a stroke, so that there's no valvular heart disease, no significant carotid or ascending aortic disease, and no intracranial vascular disease, then you have to really look very hard for the presence of paroxysmal atrial fibrillation. We don't do implants, but we do prolonged monitoring. So we can do a Holter monitor for like 4-day Holter monitor, 96 hours. And I know the rate of discovering atrial fibrillation is less than when you do an implant, right. But at least you can pick a lot of patients who have occult, who have paroxysmal atrial fibrillation when you do these maneuvers. But you have to do full workup for these patients. You have to look for the presence or absence of paroxysmal atrial fibrillation by prolonged Holter monitoring. You have to do an echocardiogram to look for valvular disease. If you have any suspicion of the presence of a thrombus in the left atrial appendage, then you have to also pursue that. But these patients need to be worked out very carefully, because if they get a stroke and they get out of it, it's a TIA or simple stroke, then their next stroke might be a serious one, and they might end up with a significant mortality or morbidity. But I don't think in Jordan we do, I'm not aware, maybe if we have an electrophysiologist can help us, but...
Because currently our practice is to...
Yes, implant. I know, but we don't have them in Jordan yet, I don't think.
But that has to take consideration of what his CHA2DS2-VASc score. If his CHA2DS2-VASc score is very low, that makes a difference in the equation. You should look for a different pathology, definitely. If his CHA2DS2-VASc score is high, I think atrial fibrillation could explain the stroke. And each patient is selective, but definitely CHA2DS2-VASc score would help you a lot in your workup, I think.
Are there monitoring, like 30-day monitors?
Yeah, we have event monitors for 30 days.
30 days.
And nowadays, I advise my patients to buy iWatch. It is really helpful to identify some.
It's
arrhythmias.
actually
It's
the only thing
cheapest.
FDA approved.
It is the cheapest device available and we are working now with the company to get it registered in Jordan because it is not, arrhythmia monitoring is not registered in Jordan. So we're working with them to help us to do that.
You have to activate it in the US. That's what I did with my parents.
Apple Watch.
دكتور محمد معلش سؤال for those who present with the cryptogenic strokes and they are at the middle age and you look for cardiac causes for thromboembolism and don't find structural abnormalities, no PFO, and their thrombophilia did not show any abnormality. Do you have the right to suspect atrial fibrillation and to anticoagulate those patients?
What we do is currently it's become the standard of care where you have to implant either a Micra, which is a small monitoring device that lasts for up to 3 years, or a 30-day event monitor, but you can kind of, it's like a little sticker. The event monitor is like, it's a Zio patch that goes for 2 weeks and then you renew it, or a Preventus, which is a 30-day, but it's just a sticker. So it's very convenient. But this is what we do. You have to monitor because it's up to 30% of cryptogenic strokes are because of atrial fibrillation that's been undiagnosed. So it's very, very important, especially that oftentimes the second stroke could be more catastrophic than the first one. But we do not start someone on blood thinners, on anticoagulation, just because they came with a stroke. Because their stroke, I mean, we all know all the different adverse events that can happen from a blood thinner that's not needed. But this is what we're doing. We don't really start a blood thinner. We just do the monitoring, and once we see any type of AFib, even if it's a short run of AFib, we start the patient right away on blood thinners. Any more questions?
No. Okay, we
All right.
conclude the session. Thank you,
Great.
everybody.
Thank you.
I think dinner is served at 7 o'clock.
All right.
Do we know where? برج الحمام. والله هذا الحمام راح يطير هلا.